Okay, so for the next subject in the radiology club is phakomatosis by Dr. Khanda Karim.
Good morning, everybody. Phakomatosis are groups of disease. The term derived from the Greek root phako, which refers to the lens. Phakomatosis thus means a tumor-like condition of the eye. We have common more than 60 disorder. Common are neurofibromatosis type 1, type 2, tuberous sclerosis, third Werber syndrome, and von Hippel-Lindau disease. And we have many uncommon diseases. Neurofibromatosis, we have these are autosomal dominant disorder. We have two types, neurofibromatosis type 1 and type 2. Type 1, there are mutation of the gene on chromosome number 17, and type 2, mutation on chromosome number 22. Neurofibromatosis type 1 present in children, and type 2 later age. We have cutaneous manifestation of neurofibromatosis, caveolate spot, Lisch nodule, plexiform neurofibroma, axillary freckling, and molluscum fibrosum. This is a caveolate spot, and this is a melanocytic hamartoma of the eye. This nodule, and these are plexiform neurofibroma, and this is molluscum fibrosum. Imaging, regarding the imaging of neurofibromatosis type 1, we have scalp, skull, meninges, and orbit. We have cutaneous scalp plexiform neurofibromatosis, and they are solitary multifocal scalp nodules. May infiltrate and extend into cavernous sinus. Also, we have sphenoid wing dysplasia, hypoplasia, and enlarged orbital fissure. Enlarged middle fossa and temporal lobe may protrude into the orbit. Dural ectasia, we have tortuous optic nerve sheaths and patulous Meckel cavus, enlarged internal auditory canal. This image showing multiple neurofibroma, solitary they are, but multifocal.
You can see there in the skin there are some
Yes.
nodules, multiple in the skull, bilateral.
Yes. Also, sphenoid wing dysplasia, it is not pathognomonic, but if we have, it is characteristic of neurofibromatosis.
What's the sign here?
Bare orbit
sign.
sign.
We presented it, I think, last week.
Yes. Absence
Nice.
of the line and
Bare orbit sign.
yes. Also, in this coronal fat saturated contrast enhanced magnetic resonance imaging show right plexiform neurofibroma. The lesion is heterogeneously enhancing, extending along the anterior frontal calvarium.
The whole thing,
Yes.
all the scalp and extending into the orbit, all of it is one big plexiform neurofibroma. Everything white.
Yes. Also, this image, axial post-contrast CT show deformity of the right greater wing of the sphenoid bone and the right posterior lamina propria. Also, enlargement of the middle cranial fossa is visible and showing result in the right side proptosis of the right and ophthalmos. Ophthalmos means protrusion. Ophthalmos, protrusion of the eye ball. Most of them, they are presented with proptosis later on. Regarding the brain, we have hyperintense T2 flare wide matter foci. They are not enhancing. Wax in the first decade, then wane. Rare in adult. Also, we have astrocytoma.
What do you mean by wax and wane?
Yani they appear, then disappear.
Okay, they come and go.
Yes. Astrocytoma, most common we have pleocytic astrocytoma in the optic pathway of hypothalamus and brainstem. Malignant astrocytomas are rare. Arteries, we have progressive internal carotid artery stenosis, myomyo, and fusiform. Moya. Yes, it is idiopathic non-inflammatory, the stenosis of the arteries and resulting in collateral formation and like a puff of smoke.
Smoke sign. From which language?
Japan.
Japanese, exactly. Good.
More invertebral than the carotid. This is phasis. This foci of abnormal signal intensity is seen in 70% of children with neurofibromatosis type 1.
Foci
Of
abnormal
abnormal.
signal in NF1 you can see as T2 hyperintense foci.
Yes.
Like sometimes they call it unidentified bright objects.
Yes.
Sometimes they call it.
Previously, I think this is. Also, optic glioma, it's a real condition. They appear low in T1 and high in T2 when it present mostly characteristic of neurofibromatosis. This is the image of multiple short collateral formation. And
You can see due to stenosis of the
Stenosis,
ICA. Okay, just right here at the arrowhead.
Yeah.
Point at the arrowhead, okay. There is a narrowing of the ICA, resulting in development of collaterals. This happens over a long time, not like a CVA immediately. So giving time for collaterals to develop. These collaterals will appear as like a puff of smoke.
Yes.
Sometimes conjunctivally too, ICA absent also moya.
Yes. Moya is a sign
Yes.
that indicates stenosed ICA with collateral development as a differential.
Yes.
One of them is a neurofibromatosis.
Neurofibromatosis. Thoracic manifestation of neurofibromatosis, we have mediastinal masses and lung parenchymal disease. In mediastinum, we have neurofibroma formation, lateral thoracic meningocoele, and extraadrenal pheochromocytoma. And in parenchymal, we have interstitial fibrosis and bulla formation. This lateral thoracic meningocoele, there is well-defined mass, paravertebral mass, and the signal intensity is like the CSF because it is
Meningocoele. It's from the meninges.
in thoracic also associated with kyphosis. They are features of neurofibromatosis. In skeletal neurofibromatosis, we have skull. We discussed this sphenoid wing dysplasia. Also, we have enlarged neural foramina and lambdoid suture defect. In the spine, we have posterior vertebral scalloping and scoliosis. In the rib, we have rib notching and ribbon ribs. Long bone, we have pseudoarthrosis.
So when someone asks you what are the findings in neurofibromatosis, you have to all of these skeletal, CNS, I don't know, skin, whatever, the whole thing. You have to. There are a lot of manifestations.
This image shows pseudoarthrosis in case of neurofibromatosis. Pseudoarthrosis means like joint formation. In neurofibromatosis, there will be bowing of the long bone, especially the tibia, and there will be cupping of the one end of the proximal end of the bone and sharpening of the other end. Also, there will be this resorption of bone between them and showing joint formation.
So it's like just like a joint, but there is no joint here
formation. Yes.
at the mid leg. It's like an alien or something.
And this image is chest X-ray showing ribbon rib sign. The ribs are thin, as in this image we see, and is a feature of neurofibromatosis. And also we have kyphosis and enlargement of the neural foramen. This lateral view of cervical spine showing kyphosis and enlargement of foramen. Also, dural ectasia refer to the ballooning and widening of the dural sac, which can result in posterior vertebral scalloping and associated with herniation of the nerve root. Also is seen in case of neurofibromatosis. A diagnostic clinical feature of neurofibromatosis, at least two of the following are required. Cutaneous lesions. Yes. More than 6 caveolate spots, earliest manifestation. Pre-pubertal less than 0.5 cm more, and post-pubertal more than 1.5 cm. Freckling of the armpits and more than 2 neurofibromas in any type, and 1 plexiform neurofibroma. Eye abnormality, more than 2 least nodule, pigmented iris, optic pathway pleocytic astrocytoma, and distinctive bone lesions, sphenoid dysplasia, and long bone cortex dysplasia, thinning, family history of first degree relative. Neurofibromatosis type 1 is also known as type 2. Neurofibromatosis with bilateral vestibular acoustic schwannomas. Historically, type 2 was termed central neurofibromatosis to distinguish it from so-called peripheral neurofibromatosis. In type 2, central manifestation must be present 100% there. They have this manifestations. In pathology, the most common neurofibromatosis type 2 related schwannomas are vestibular schwannoma. Meningiomas occur in approximately half of all patients with type 2 and can be found anywhere in the skull spine. The most frequent sites are along the falx and cerebral convexities. MISME means multiple inherited schwannoma, meningioma, and epidymoma.
So this is, what are the findings in NF2? MISME. Okay? Again, go back. MISME is multiple inherited schwannomas. ME is meningiomas and ependymomas. Okay? Very nice.
The type 2 neurofibromatosis diagnostic clinical features. We have definite type neurofibromatosis type 2 or probable. Indefinite, we have bilateral vestibular schwannoma, first degree relative with type 2 neurofibromatosis, and unilateral vestibular schwannoma younger than 30 years of age. Or first degree relative with and 2 of the following: meningioma, glioma, schwannoma, juvenile posterior subcapsular lenticular opacity, or cataract. In probable of neurofibromatosis, unilateral vestibular schwannoma younger than 30 years of age, and 1 of the following: meningioma, glioma, schwannoma, and posterior subcapsular lenticular opacity. Or more than 2 meningioma and 1 of the following: 1 vestibular schwannoma younger than 30 years of age, or 1 meningioma, glioma, schwannoma, or lens opacity. They are probable, but they are definitive. And this image showing bilateral vestibular schwannoma. Also, this image showing vestibular schwannoma in case of neurofibromatosis. And these are meningiomas, falx, and
multiple meningiomas.
multiple.
So the central manifestations are more
common
in NF2.
Yes. And this is spinal multiple schwannomas.
Kull spots, all of them are schwannomas,
Yes.
tiny spots. On the MRI, you can see these tiny dark spots. These are schwannomas.
And also ependymoma. They are multiple. Differentiation between type 1 and type 2. Type 1 more common, 90% of cases, and type 2 less common. And this is mutation in 70 and 22. Almost always diagnosed by age of 10, usually diagnosed in the 2nd to 4th decade. Cutaneous lesions more common, 95%, and cutaneous eye lesions less prominent, mild few if present. CNS lesions less common, 15 to 20%, and CNS lesions is 100%. We discussed all of them, features of CNS. Thank you.
Very nice. Thank you very much. Summarization of a big syndrome in a few minutes. It's